All right, now let's talk a little bit about the joints that you should be familiar with. The first joint we'll talk about is the temporomandibular joint. This is where the head of the mandible articulates with the temporal bone in the skull, and this is the only mobile joint between bones in the skull. It has a loose articular capsule that surrounds the joint and promotes extensive range of motion, and it has an articular disc, which is a thick pad of fibrocartilage that divides the synovial cavity into two chambers. As far as movements of the TMJ goes, it's going to have hinge and gliding movements primarily. It's going to function like a hinge during depression and elevation of the mandible, and then it glides during protraction. Let's see. Here you can see the articular capsule, and here's the articular disc that divides the capsule into two. Next is the shoulder joint, or the glenohumeral joint. I want you to know that this is a ball and socket joint formed by the head of the humerus and the glenoid cavity of the scapula. Okay, and this joint is going to be the one with the greatest range of motion in the body, but it's also the most unstable and the most frequently dislocated of the joints. There's a fibrocartilaginous labrum that encircles the socket, the glenoid labrum, and abundant bursae. This is going to decrease friction where the tendons and the muscles extend across the capsule. The glenohumeral joint has several supporting ligaments and tendons. The coracoacromial ligament, the coracohumeral ligament, and the glenohumeral ligament, as well as the tendon of the long head of the biceps brachii. But most of the joint stability is going to be due to rotator cuff muscles, and these are the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. These work as a group to hold the head of the humerus in the glenoid cavity, and the tendons encircle the joint and fuse with the articular capsule, and I'll show you what I mean here in just a second. So here's the shoulder joint. You can see extensive ligaments and extensive bursae as well. Here we can see it from the lateral view, and you can see the tendon of the long head of the biceps brachii kind of inserts right here. You can see the infraspinatus tendon, the teres minor muscle, the subscapularis muscle. These all are kind of circling the head of the humerus, keeping it stable, okay? And you can see the head of the humerus here, and again the muscles and the tendons inserting and keeping the humeral head stable. The next joint I want you to be familiar with is the elbow joint. The elbow is a hinge joint that's actually composed of two articulations, the humero-ulnar joint and the humero-radial joint. The humero-ulnar joint consists of the trochlear notch of the ulna articulating with the trochlea of the humerus, and the humero-radial joint consists of the capitulum of the humerus articulating with the head of the radius. Both of these joints are going to be enclosed within a single articular capsule. So you can see here a sagittal view of the right elbow. You can see humerus here. Here's the trochlea of the humerus, and it fits into the trochlear notch of the ulna. Here's the articular capsule. And you can't see from this view, but it's also enclosing the humero-radial joint. Here, from an anterior view, if you took away all of these ligaments, this would be the capitulum of the humerus, and this is the radial head right here. The elbow is a very stable joint because the articular capsule is thick, because the bony surfaces of the humerus and ulna interlock closely, and because there's multiple strong ligaments that reinforce the articular capsule. Chiefly the radial collateral ligament, the ulnar collateral ligament, and the annular ligament. The radial collateral ligament stabilizes the joint at the lateral surface, okay, and the ulnar collateral ligament then is going to stabilize the medial side of the joint. The annular ligament surrounds the neck of the radius and basically binds the head of the radius to the ulna. So here we can see the ulnar collateral ligament on the medial side, and you can see the radial collateral ligament here on the lateral side, and then here's the annular ligament binding that head of the radius there. Okay, clinical application. We'll talk about the subluxation of the head of the radius. This is also called nursemaid's elbow. Subluxation is an incomplete dislocation, and what happens in nursemaid's elbow is there's a subluxation of the head of the radius where the head is pulled out of the annular ligament. This occurs almost exclusively in children under 5 years of age, and it's because the child's annular ligament is thin and the radial head is not fully formed yet. This usually occurs from a sudden pulling or tugging motion on the arm, like when a caregiver goes to pull a child up by their arms, and requires a maneuver to pull the radial head back into the annular ligament. And what the physician usually does is they will supinate the forearm while flexing the elbow to about 90 degrees, and they're feeling for a click or a pop where that radial head pops back into the annular ligament. Next, we'll talk about the hip joint. This is the articulation between the head of the femur and the acetabulum of the os coxa, or the hip bone. It contains an acetabular labrum, which is a fibrocartilaginous ring that deepens the socket. And this joint's going to be more stable and less mobile than the glenohumeral joint. Support of the hip joint. This is secured by the articular capsule, ligaments, and muscles. The articular capsule extends from the acetabulum to the trochanters and encloses the femoral head and neck. And there are retinacular fibers there that I want you to be aware of. These are ligamentous fibers of the articular capsule that reflect back around the femur's neck, helping to stabilize the joint. And they also contain arteries, retinacular arteries, that supply most of the blood to the femoral head and neck. Okay, and then there are several intracapsular ligaments, the iliofemoral ligament, the ischiofemoral ligament, and the pubofemoral ligament. What I want you to know about these is that they provide support to the hip joint. There is a ligament of the head of the femur. This is called the ligamentum teres. That's a small ligament that goes from the acetabulum to the fovea of the head of the femur, and it does not really provide stability. What it does is it contains an artery that supplies the head of the femur, and it also contains proprioceptors, which are mechanoreceptors that can sense changes in position. So it gives the brain feedback on the position of the hip joint. So here you can see the acetabulum of the hip, and here's the head of the femur and the neck of the femur. You can see the articular capsule surrounding the head and neck, and here are those retinacular fibers that reflect back, right, and contain that arterial supply for the head and neck. And here's the ligament of the head of the femur. And again, this does not provide stability. This provides an artery and proprioceptors, all right? And you can see it here. You can also see the acetabular labrum in this view here. All right, and here you can see the ligaments that give stability to the joint, the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament. All right, clinical application. We'll talk about fracture of the femoral neck. This is often referred to as a fractured hip. There are a couple of different fractures we'll talk about. Intertrochanteric fractures. This is going to be a fracture that's extracapsular, so outside of the articular capsule of the hip. And you'll see this usually in younger and middle-aged individuals. Contrast that with the subcapital fractures. And these occur within the hip articular capsule, and you usually see this in older people who have osteoporosis. This can result in tearing of the retinacular arteries, which again feed the femoral neck and head, And so if you tear those arteries, you can have what's called avascular necrosis in the region where the bone dies away because it's not getting blood flow. Okay, so here's an example of an intertrochanteric fracture. You have the greater trochanter here, the lesser trochanter here, and you can see the fracture line right through those trochanters, okay? And this is outside of the articular capsule of the hip. Compare that to a subcapital fracture. Here, you can see the surgical neck of the femur has been fractured. This is within the articular capsule, right? And this can affect those retinacular arteries, can lead to avascular necrosis of the femoral head and neck. Next, we have the knee joint. This is the largest and most complex freely movable joint. It primarily functions as a hinge joint, but it is capable of slight rotation and lateral gliding when flexed. It's composed of two separate articulations. You have the tibiofemoral joint. This is going to be between the condyles of the femur and the condyles of the tibia. And you have the patellofemoral joint. This is going to be between the patella and the patellar surface of the femur. Structures of the knee joint, you have an articular capsule, and this is going to only enclose the medial, lateral, and posterior knee regions. And on the anterior surface, you have the quadriceps femoris muscle tendon. This passes over the anterior surface and surrounds the patella. You also have the patellar ligament, the fibular collateral ligament, and the tibial collateral ligament. The patellar ligament extends from the patella to the tibial tuberosity. The fibular collateral ligament reinforces the lateral surface of the joint, and this is going to extend from the femur to the fibula and prevents hyperadduction. And you have the tibial collateral ligament, which reinforces the medial surface of the joint, extends from the femur to the tibia, and prevents hyperabduction. Then you have the medial and lateral meniscus. This is going to be deep to the articular capsule within the actual knee joint, and these are C-shaped fibrocartilage pads on top of the tibial condyles. They act as cushioning between the articular surfaces, and they change shape to conform to the articulating surfaces. They work to partially stabilize the joint medially and laterally. Next, you have the cruciate ligaments. These are so named because they form a cross. They cross each other, and this is also deep to the articular capsule. You have the anterior cruciate ligament, or the ACL. This is going to extend from the posterior femur to the anterior tibia, and it prevents hyperextension and anterior displacement of the tibia. So anterior cruciate ligament prevents anterior displacement of the tibia. Then you have the posterior cruciate ligament. This is going to extend from the antero-inferior femur to the posterior tibia, and this prevents hyperflexion and posterior displacement of the tibia. So posterior cruciate ligament prevents posterior displacement of the tibia. Okay, so here we have a superficial view of the knee joint. You have the quadriceps femoris muscle, and the tendon of this is going to glide over the anterior surface of the femur. You have the tibial collateral ligament here on the medial side of the joint, and the fibular collateral ligament on the lateral side of the joint. You have the patellar ligament extending from the patella down to the tibial tuberosity. Now we have our cruciate ligaments we're going to look at. You have the ACL, which extends from the posterior part of the femur to the anterior part, the tibia here. And then you have the PCL, which is going to be from the anterior-inferior part of the femur back to the posterior part of the tibia. And you see how these kind of cross one another. You also have the lateral meniscus and the medial meniscus. You can see in both the anterior and the posterior views here, cushioning this joint space and adding stability to it as well. Clinical application, just some general information about knee ligament and cartilage injuries. So you can injure your tibial collateral ligament when you forcibly abduct your leg. The fibular collateral ligament can be injured when the medial side of the knee is struck. Okay, so that would tear the lateral side. You can have an ACL injury when the leg is hyperextended, and a PCL injury when the leg is hyperflexed. You can injure your meniscus due to trauma or overuse. And then there's this thing called the unhappy triad. This is going to be injury of the tibial collateral ligament, the medial meniscus, and the ACL, and this occurs due to a lateral blow to the knee that abducts and laterally rotates the leg. But if you were to look at all of these and take away anything from it, I would focus on the ACL and the PCL injury. These like to be tested to make sure you know which one does which. Okay, so the ACL is going to be anterior displacement of the leg, or when the leg is hyperextended, and PCL is going to be posterior displacement of the leg, or when the leg is hyperflexed. Finally, we have the talocrural, or the ankle joint. This is a highly modified hinge joint that permits dorsiflexion and plantar flexion. Anatomical features of the ankle joint. So you have a medial malleolus of the tibia and a lateral malleolus of the fibula. Both of these prevent the talus from sliding medially or laterally. You have an articular capsule that covers the distal tibia, the medial malleolus, the lateral malleolus, and the talus. On the medial side, you have the deltoid ligament that binds the tibia to the foot, and this is going to prevent over-eversion. And then on the lateral side, you have the lateral ligament that binds the fibula to the foot, and this prevents over-inversion. The lateral ligament is particularly prone to sprains and tears. And then you have the anterior and posterior tibiofibular ligaments. So here we're looking at the right foot. This is the lateral view. So you can see here's the anterior tibiofibular ligament. Here's the posterior tibiofibular ligament. Here's the lateral ligament. And if we look on the other side, the medial side, you can see the deltoid ligament here. For clinical application, we'll talk about sprains and we'll talk about pod fractures. Okay, so sprains, this is going to be a stretching or tearing of the ligaments without a fracture or dislocation. And it results from twisting the foot, usually over inversion. The fibers of the lateral ligament often are stretched or torn, and there can be localized swelling and tenderness, inferior to lateral malleolus. Next, you have the pons fracture. This occurs with over-eversion. The medial malleolus is avulsed, which means it's torn off of the tibia. This is a type of fracture called an avulsion fracture. The talus moves laterally and fractures the fibula. So you have a couple things going on there. Here's a picture of it. You have the avulsion fracture here, where this part of the tibia has been pulled off. And you see how the talus has shifted and has fractured the fibula. So they go in and they surgically repair this with screws and a plate on the fibula. Okay, so development and aging of the joints. Joints start to form by the 6th week of development. For future fibrous joints, the mesenchyme differentiates into dense regular connective tissue. For future cartilaginous joints, the mesenchyme differentiates into fibrocartilage or hyaline cartilage. And for future synovial joints, the laterally placed mesenchyme forms articular capsule and supporting ligaments. And then the next layer of mesenchyme forms the synovial membrane. And centrally located mesenchyme may be reabsorbed or form menisci or articular discs. The whole kind of takeaway from this is that joints are going to be formed from the mesenchyme, okay? Arthritis is going to be something that can affect the joints, especially as we age. But there are 2 types of arthritis that we generally are talking about. When we say arthritis, usually we're talking about either RA or OA. So RA is rheumatoid arthritis. This is an autoimmune disease involving damage to the articular cartilage. Osteoarthritis, on the other hand, is going to be aging of the joint due to wear and tear on that articular cartilage, okay? So osteoarthritis is a physical disease, a disease due to physical wear and tear, whereas rheumatoid arthritis is going to be a disease of autoimmunity. Exercise and joint health. Exercise can help keep your joints healthy. It can increase the flow of synovial fluid to the chondrocytes, can strengthen the muscles that support and stabilize the joints, but extreme exercise can aggravate potential joint problems and can cause or worsen osteoarthritis. Okay, I know I just said that there are two types of arthritis, but I should make mention of the third type, gouty arthritis. This is typically seen in middle-aged or older males. It's usually seen in the joint of the great toe, and it's due to increased levels of uric acid. Often this is due to the influence of the diet, so large amounts of red meat, red wine, things like that can increase uric acid levels, but it can also be due to decreased clearance of uric acid through the kidneys, okay? And just to give you an idea of what gout looks like, so it's deposition of uric acid crystals in the joint space, and this is exquisitely painful. It's treated with medication that helps resorb this uric acid and helps you eliminate it.